So I will talk about the transcortical, transventricular endoscopic approach to cystic craniopharyngioma. And we'll try to explain why I think it's important and an important concept. So that's typical cases, cases that we see very often in children. And that may be, again, also a difference to the adults that we discussed this morning. And I will show it more, is that the prevalence of cystic craniopharyngioma in children is much higher than in adults. Up to 90% of the pediatric craniopharyngioma are partially cystic or mainly cystic, with a small solid component, smaller solid component in the right image, a slightly larger solid component in the left image. So I think it's important to have a concept for this type of craniopharyngioma that might be different. So this is a beautiful illustration from Hermann Müller's paper, differentiating the two subtypes, the adamantimatous and the papillary type. And we see that there is two peaks, the children and the adults, as we already heard this morning. And I think important is like up to 90% of craniopharyngioma in the pediatric population is adamantimous and has cystic components. So the cystic components is more prevalent in the pediatric population. Therefore, also the preoperative hydrocephalus has a higher incidence in the children because of this cystic component that will obstruct the third ventricle and the foramen of Monro. And we have a very high incidence of endocrine dysfunction to start with already. So at initial presentation, in one of the series, 80%, but the literature, of course, maybe goes from 50 to 80%. But there seems to be a higher incidence of endocrinological dysfunction in a growing child. Interestingly, visual disturbance is less than in the adults. So we already heard a few times there is certain differences, not only in the biology, but then also in the clinical presentation. So that means that the cystic craniopharyngioma is an important entity and I think asks for some considerations. Now, of course, that image should not be like that, but I'm not sure I can change that. So you just, flip it in your mind. So I think we have two situations. We have the situation where we have mainly solid tumor. We have mainly solid tumor, like in the upper example, with invasion of the hypothalamic structures, or we have a craniopharyngioma with a very small solid component, maybe a small cyst, that would be considered Puget grade 0, so that is really cellular and minimally supracellular, but really has no invasion of the hypothalamic. So this is, decision-making type 1. And then, on the other hand, we have the decision-making type 2, where we have mainly a cystic component, partially with hydrocephalus, like in this image, with smaller, like these two, or somewhat bigger solid component. But the approach really, I think, has to be differentiated between the two. And so we already heard about the Puget classification that I think really helped us decide what kind of approach should we take. Should we see craniopharyngioma that is a Puget 0, where we actually have a chance of a complete, of a gross total resection through a transnasal, transphenoidal endoscopic approach, or do we have a cystic component that can be approached with a cyst, with the treatment of the cyst, with hydrocephalus, and then mixed components that have the invasion also of the hypothalamus. So if you go down, raised intracranial pressure, hydrocephalus, yes, cystic component, yes, then consider cyst drainage, because this is the acute problem of the child with a chronic disease. The acute problem is a hydrocephalus. So of course, you will consider doing the cyst. No, not urgent, so we go in the other pathway. And then, as I said, the grade 0 with no hypothalamic involvement. Can we go for a complete excision? Usually, I think transphenoidal endoscopic. incomplete and then follow up, or complete. And then in the grade 1, there is maybe some discussion points. Where should we go? And in the grade 2, very clearly, we should go for a subtotal resection followed by radiation, depending on the age. So I think this decision tree is not complete, but at least gives us an idea on how to think about it. And on the right side, you see the different classification. Puget, as somebody said, French and simple. I did like that. And actually, Stephanie is actually like that. And Christian Saint-Rose too. They're straight thinkers. So it's easy to remember. So in our minds, I think we need to do this initial decision making. We have already heard why is there even the discussion about the problem. And the problem is really one of the problem, and we heard it, of course, this morning, so I will not deliberate too much, the body mass index, the hypothalamic obesity, that in this study was investigated at M0, at presentation, 6, 12 months, and more than 12 months in extensive resection surgery and hypothalamic saving surgery, HSS. And we see a significant reduction in the incidence of weight gain if you go for hypothalamic sparing surgery. So we've heard this morning already, and the same is true for endocrinological dysfunction when you look at these two attitudes of surgical plan. So again, think this is a Puget grade 0, so a small craniopharyngioma. A bit difficult to imagine for you, but you see very small cyst here, very small solid component. So if you have a situation like this, and this is not the content of my talk, then I think you can decide to go for a gross total resection, depending on the endocrinological status. And that's what we did here too. So going for a transsphenoidal surgery. I should have brought my laptop. But anyway, so we've seen the videos. I hope the other videos work. Maybe we should get the technician if the other videos don't work. I will hook up my laptop.
Can you try again?
Yeah, I think there is a codec problem because they didn't load the converter on their computer here. So I think this is a kind of a straightforward decision making. Puget grade 0, we can aim at gross total resection with good results. Still we know, and Mahmoud already showed it, that we have also in the transsphenoidal surgery a high incidence of endocrinopathies. And really, I think there the decision is, and we've discussed it, should we go for surgery? Or maybe if it's really small, Puget 0, should we just go for radiation and actually have a higher chance of preserving endocrinological function, avoiding surgery. So I think this is an ongoing discussion. But of course, there's many surgical series that demonstrate that the odds ratio of having a endocrinological dysfunction is 9 if we go for a GTR, also in endoscopic transsphenoidal surgery. So also there we have a high incidence. Ja, genau. Das ist schnell. So. Jo, danke vielmals.
That's the important point. 9 out of 10 will have panic of pituitary.
Yeah, so it's a really high number. Yeah. Even in a Western country, it is an impact on quality of life. But of course, managing it like in Switzerland, let's say, is easier than in less developed countries. But still, it's an impact, and mainly the diabetes insipidus. So having the minirin and having a good balance is a difficult task. But yes, 9 out of 10 will get the endocrinological dysfunction. And I will move forward to this. This is also an interesting summary that was also in the Nature Review, but taken from an earlier paper in Neuro-Oncology from 2015, comparing the overall survival and progression-free survival if you have no hypothalamic injury or if you have hypothalamic injury, and you just see a significant reduction in overall survival with a more aggressive surgery. But not really a difference in the progression-free survival. So we're really not doing any good because we don't get a true benefit on progression-free survival, but we get a reduction in overall survival. So we're not really achieving what we want. So we have adopted a strategy that when we see a child with a cystic craniopharyngioma, we will opt for a transventricular endoscopic approach to treat what is probably bothering the child at the moment of presentation. And so in Pt.2, but certainly in Pt.3 cystic craniopharyngioma, we would always try to first treat the cyst, putting in a catheter and an Ommaya through an endoscopic approach. So I will set up a little stupid detail, but I don't know, those of you who do endoscopic surgery, the navigation star never holds on the metal. So just put a small rubber tube from the suction, you cut out a piece of your suction, you put it around your endoscope, and it's rubber, and your star will actually disappear. Okay, it's coming back. Your navigation star will actually hold on the endoscope. I think we're losing the life of those beamers here. Okay, so this is just a stupid small detail, but we do navigate the endoscope in all those cases. Then, of course, we like to have instruments, independent of the company, of course, but instruments to do the fenestration and do the biopsy and maybe do a partial internal decompression if we see that it's amenable. So I will show you a first case. This was an 11-year-old boy with short stature. So we heard already this morning, this is often a presenting symptom, short stature in children. He also had a reduced IGF-1 on his labs, normal vision. And you see this mainly cystic craniopharyngioma, probably with multiple cysts. So we have a bigger cyst in the back, maybe a smaller cyst in the front. But from the top, you see how it spreads. It's a peduncular cistern with some compression on the brainstem and compression in his third ventricle. So we started with a endoscopic. Here we go. We started with an endoscopic fenestration of that cyst. So we always use a peel-away sheet. Here we go through the right lateral ventricle. You see the foramen Monroe. You see the choroid plexus. You see the fornix that we of course always try to preserve. Here the view, now limited view into the third ventricle, but here you see the surface of the cystic craniopharyngioma coming into the third ventricle with these calcifications on top. The choroid plexus was bothering us when going through, and we didn't want to get a bleeding from the choroid plexus, so you can coagulate partially at least the choroid plexus. And limit maybe a hemorrhage from the plexus when manipulating. Then coagulating with the monopolar, the surface of the cyst, and perforating the cyst. And you will see how cystic motor oil fluid will get out of the cyst. Now, all of you may be saying, chemical meningitis, this fluid coming into the ventricular system. So you do irrigate all the time, but the literature actually shows that this chemical meningitis is extremely rare. So I think with surgeons, we all think, this fluid coming out here, I aspirate it with a tube and a needle. But if you look at the literature, actually the chemical meningitis due to the cyst fluid is actually extremely rare, but it can happen. So we always irrigate. Then we go, please.
Have you considered in this case, because the vents are small, to just put it stereotatically?
Yes. So this is a good point, and I think I will. I don't know why it's.
Yeah, it's bad.
keeps on stopping. Yes, it is a consideration that you could go purely stereotactically. We thought the ventricles are large enough and the foramen of Monroe dilated enough, so we can go in. Ja, es ist gut. Es ist nur schwarz. Es ist gut. But it is a consideration that you could go in purely by stereotactic means. We wanted to take a biopsy. We wanted to do a little bit of internal decompression, but you commented maybe that the tissue diagnosis is not necessary. We do the molecular analysis, and that might not have consequence now, but we have biobanking and so forth. So we do take biopsies. So you see the evolution of before the surgery and after in different planes. And what you see actually is the catheter is here. So the cyst, the big cyst that we drained, did get smaller. And I show this case because it was a bit more complex. This anterior cyst that was very small before actually kind of expanded upon reduction of the big cyst in the back. So he had this smaller cyst, but at this point that was asymptomatic. So we went into an observation phase. We had a lot of discussion. Should we go for radiation up front? At that time, we were still kind of struggling. Should we not? Maybe today we would do it. But that was the story. And then that small cyst that was not drained got larger. So the catheter is back here. That big cyst is still drained perfectly, but the small cyst in front got larger and now started to become symptomatic again. Through compression of the ventricular system, he had more headaches, and so we decided to go for a second endoscopic surgery. So you will see once entering the third ventricle. Here is the catheter that was in the back cyst, and here is the front cyst that we go, as I said, navigated, and we fenestrated the front cyst and then connected the two cysts, actually. So we took away the posterior wall of the anterior cyst and connected the two cysts to make it one cyst, and at the end move the catheter kind of between the two cysts with additional holes in this silver line catheter connected to an Ommaya reservoir. So I can move forward here. So in the end, we grab the catheter and see if I can. Then we moved it basically into the two cysts, so it would drain the two cysts. And with this we were quiet for a while. But as it happens with those tumors, they develop multiple cysts, and that's sometimes how they grow. And you see here multiple cysts, but still the pressure on the third ventricle was less for a while. But then the solid component started growing, and as we said, it's this benign malignant tumor that behaves in this way. So anytime I walk away, I should just stay here, not walk. But you see, the solid component grew, and then we decided to go for an endoscopic transphrenoidal surgery. But again, lots of discussion: should you radiate or not? And maybe we would change the attitude now, but at that point we had decided to go for a transphrenoidal endoscopic partial resection, not injuring the hypothalamus, and you see we left a remnant to avoid hypothalamic injury. So complex cases, as you know, they are. I show you a second case, here a more calcified lesion, Puget grade 2. Now this child, as you can recognize, was obstructive hydrocephalus, and the typical signs of elevated intracranial pressure with headache, nausea, vomiting, and visual impairment. First step again, we did an endoscopic treatment of the cyst. You see here drainage of the cyst. Now we had that large solid component. Again, discussion, radiation versus surgery. We decided to do a transsphenoidal surgery as a step 2, and I will, skip the surgery as we have seen it before. But again, with the clear goal of leaving the tumor up here, just taking the solid component at the bottom. So again, sparing the hypothalamic area, so treating the cyst first, and then treating the solid tumor part, but preserving the hypothalamic structures. Then he was good for a while, he was stable with some hormone replacement, and then he developed that small cyst here that was actually causing a unilateral visual deficit. It was just pushing on the tract, and so he got many ophthalmological examinations, and in the end we decided to treat the cyst again through endoscopic transventricular approach. So here again going through the pilloway sheet, the anatomy of the lateral ventricle, nicely demonstrated with the septal and thalamus striate vein, the plexus choroideus, and then going through the foramen Monroe, where we will identify the catheter that had initially been placed, all again with neuronavigation. Because without neuronavigation, I don't think that you would be able to identify the cyst that is actually hiding behind the catheter. So with the navigation, we find the cyst and go treat the cyst. Here we perforate the cyst that is lateral of the catheter and drain that small cystic component that was creating symptoms, and the symptoms recovered after surgery. So I think this is an approach that can achieve a few things. First of all, it can get the child out of trouble if you have hydrocephalus symptomatology or any elevated intracranial pressure symptoms. And you can gain time if the solid component remains stable, especially in young children below the age of 3 to 5, where we don't want to do radiation. We can maybe delay the start of radiation therapy using just an approach where we're going to perforate the cysts. The complications are rare. This was a series that looked at the complications, small complications like skin infection, meningitis, hemorrhage from the interventricular manipulation. But overall, I think a surgery that can be done safe. Now, the recurrence rate, we know that independent of what we will do, whether we do neuroendoscopic, endonasal, microsurgical, or Meyer reservoir, there is going to be a high incidence of recurrence that is not different between the different techniques. So we don't necessarily need to think about the problem of tumor recurrence. Here, a German study that looked at their series of 79 patients with a suprasellar cystic, solid, and sellar supradiaphragmatic tumors, where they did transnasal surgery in the purely solid craniotomy, and in the cystic one they did a stereotactic insertion of drains, and then they compared the progression-free survival of those patients. And here is the overall progression-free survival, and we know that this is quite low. There was a difference in progression-free survival, but not significant, between the solid or predominantly solid versus cystic tumors. So both have a recurrence. And here you see that the technique that you apply to treat microsurgery versus stereotactic insertion of catheters or endoscopic insertion of catheters does not lead to a significant difference in the progression-free survival. What you see, and again, is that the endocrinological differences. If you do microsurgery, you have an increased incidence of endocrinological dysfunction as compared to stereotaxy. If you compare pre and post stereotaxy and pre and post microsurgery, for instance, for diabetes insipidus, we know that you will get a higher occurrence of endocrinological dysfunction. I will skip this one. So neuroendoscopic versus stereotactic surgery. So here a study comparing purely neuronavigated insertion of catheters versus neuroendoscopic approach. You will see here that the communication between the craniopharyngioma cyst and the CSF space was created with both techniques in a high number of patients. So this worked out well. But the recurrence rate tended to be lower in patients undergoing endoscopy versus stereotactic technique. So the recurrence of the cyst in terms of if you just put a catheter or if you actually open up the cyst and put in a catheter. But overall, of course, it's still a small series, but there seems to be a slight advantage if the ventricles permit to go in with an endoscope.
But Raphael, you can always tap the Omaia.
Sorry?
I mean, I could always tap the Omaia.
Of course.
This is why you have an Omaia.
Of course.
There, right?
No, I know. You can tap it. They did tap the Omaia too, but they then they block, for instance, or there is different other problems potentially. Yeah. But of course, yes, you can tap the Omaia. So I think in conclusion, here we can say neuroendoscopy transventricular approach is a valid approach with a low complication rate for this mainly cystic craniopharyngioma. Postoperative endocrinological deterioration and hypothalamic obesity, I think it has a lower incidence with an endoscopic first approach as compared to microsurgery. The cystic tumors maybe have more recurrence actually as compared to the solid ones, especially if you have multiple cysts, and these multiple cysts tend to come back after you drain one, another one might open, and so they have a shorter progression-free survival. It can maybe help you delay radiation therapy to older age of the child, and then apply your radiation therapy by first treating the cysts. So with this, I want to thank you for your attention and open to questions. And and I just wanted to say that unfortunately Mike Edwards, that was planned on the scale now, due to family problems, health problems, couldn't unfortunately not come this year. So I think he might be online, but he's not here for the discussions.
Sorry, I thought you mentioned the
no, I have not.
So we have plenty of time.
So we have plenty of time.
But I think your talk was very didactic also from the workflow. It's a proposition of the workflow based on the literature and your own experience, and also the surgical options we have discussed here. I believe it's a good talk to ask questions.
Well, I agree that sometimes when you have hydrocephalus, and especially if you want to do a septum pellucidotomy, it makes sense to go with the endoscope. The reason we leave the catheter behind is that even after radiotherapy, it may take up at least a year until the cyst-producing mechanism stops. So when you have a conduit inside and you can tap it through the Omaia, the fact that the cyst reaccumulates does not represent a failure of the radiation, at least not in the first year. I've seen that one case for 2 years that we had to tap, and then it stopped. Now there's a silly surgical comment is when you do it with the endoscope and when you open and you debulk, basically you create a communication between the cyst and the ventricle. So sometimes you leave a catheter behind, but when you try to aspirate, you aspirate CSF and not the cyst, because it's a little silly plumbing, things that can happen. So I think if I feel that I can put stereotactically and I do not need to do a purely endoscopic procedure, it is cleaner. but it does not have, it is not free of complications. For example, if you're not aware that the catheter can slide on the wall, you know, that I'm sure that each one of you had a case like this, that you put it in, you're against the wall, you try to push, you go in, you suck, you get fluid, you're happy, but you don't get the oil, you get CSF. And then you do an imaging and you see, oh, the catheter, the slides. Sometimes you have to buzz the entry point in order to penetrate because it's blind, as opposed to the endoscopic where you see what you're doing.
So with Mike Edwards, we did a lot of stereotactic insertions. And somehow I got burned by having catheter slide in all directions because the wall is actually quite hard. And then I thought, you know, well, the endoscope is, you know, fairly safe, I'd say, and I can put it in under vision. And so, you know, I started liking that. But I get your point,
what
of
we
course.
do, we put the stylet a few millimeters protruding from the catheter. So when you hit the wall, you buzz, and you fall inside. But it's that's an issue. You do it blindly.
Did you see bleedings from that?
No.
Because we see that the wall is also a little bit vascularized.
Could be vascular, calcified. I haven't seen, but I guess it can happen.
So similar technical problems as we have in abscesses sometimes.
Yeah.
More questions, comments? Just one sentence maybe in your talk. Let me say, is that right? So kind of say, well, recurrence should not be in your mind or too much in your mind when thinking about what's going to be my treatment tree. So I was thinking that we are facing some other topics in skull-based surgery that we are getting more and more. That's what we noticed. We're more reluctant to be radical or to have a concept of complete removal. That opens the question about repeated treatment and repeated operations. The case you showed was 3 surgeries and we are not finished yet. I believe it's something is going to happen down the road. So maybe it's a question also to Dr. Professor Müller and to you. Don't you think that down the road we will then notice that the burden of disease or the overall burden of disease and treatment in the end makes them more chronically ill than having of course it's a provocatory remark, than being bolder and being more radical. And radical doesn't mean that it needs to be surgery, but it could be surgeries followed by regular surgery up front. So the paradigms, don't you have this feeling?
I mean, I think that the problem is the literature shows that almost independent of what approach you take, you will have recurrences. So, of course, it makes you a bit frustrated, so I understand, right? But then, since you get recurrences in most of the surgical situations, I think you don't want to risk that problem of the hypothalamus. So I think if you can do a complete resection safely in terms of hypothalamic dysfunction, even with endocrinopathy, let's say, since Shlomi showed it, is it acceptable or not? I still think this is probably the right way because the burden of disease in terms of the obesity is going to overweigh the fact that there's tumor remnant. So it's a conundrum, I don't know.
I would agree with your attitude. I know patients, they had a hypothalamic involvement, they got resected, radical resection, gastral resection, then they had a relapse, had several relapses and several surgeries, and then actually finally the decision was made to do irradiation, and then the patient and the family asked why this wasn't decided after the first surgery or at the time of the first relapse. And then after such a history, it's difficult to argue, you know it better when it's over, but actually each surgical intervention gets more difficult, has more complications, and you know each time that there is a potential of another recurrence. So we think when you do resection and you see that there's a recurrence or a progression of the residual tumor, you should think about another surgery, but then after this, you should consider to do irradiation to prevent the next relapse.
And this just to answer is points out that maybe one of the most essential questions, as was asked. First of all, it's probably timing of surgery of radiation after surgery or after diagnosis. This would probably be one of those questions that in a hypothetical RCT you would ask for.
Yeah.
The temporizing radiotherapy may be relevant with infants.
Sure.
Once in a while, you get an 8-month-old with a big craniopharyngioma. You want to bring him to a year and a half or 2 years so you can stick a drainage, especially if it's a big cystic. The other thing is that we don't know, although I have an idea, is whether radiotherapy is more effective for smaller tumors than for bigger tumors, which is a concept, for example, with acoustic tumors, you have a 1 centimeter, it's better than having a 3 centimeters, but that's different. So much thinks it's not. It does not determine the effectiveness of radiotherapy.
I was just looking around if Alessandra or...
Do we have a session on radiation?
We have a session on that.
Okay, so we can delay this. We can delay
would have been happy, that she...
But I think she would have stood up now, but she's not here.
So you are going to...
I'm going to represent the radiotherapy.
At the moment. Yeah. and then ask the question.
Alessia is coming from the PSI, from the proton facility. Yeah, I think, if we compare it to other pediatric tumors, of course, medulous ependymoma, where I think the literature is clear that you will have a benefit in survival rates long-term in medulloblastoma at least, that we still aim for radical resection without any discussion. But just in the craniopharyngioma, the literature has shown us different. So, yeah.
But that's why I think your work is so important, because although we never had an RCT, we are now changing completely the paradigm. And that is based on long-term follow-up. And so the quality of long-term follow-up will probably tell, because it goes over generations of doctors and not just only the typical 5-year survival rate or 10-year survival. It's about 50, 20, 30, 40 years. And we learn over time with that. So I think this is probably the question is, the answer is going to come with the time.